Hi everybody, my name is Sarah Temba. I am a super user and night shift charge nurse from the Ballard campus. I have taught some of the Epic workflow classes, and I wanted to make a version available on video so that people who were not able to get into the classes, I know they filled up pretty quickly, so people who could not get into the classes could get the information. Also, people who want to do some of this, to read some of these things at work where you can practice different things at the computer. I have been a super user since 2007, and I have been really involved with Swedish's version of Epic and have been working really hard to learn the Providence version so I can see the differences between the two, and hopefully help you guys out with seeing what's to come and what this next version of Epic is going to look like for us. So this slide, I don't exactly know what it's talking about, but it is talking about a change in perspective, which it is. There is a lot of ways that the Providence Epic is easier to read, has a bigger view. You can see more information within the version. As far as getting a more all-inclusive view, we'll be talking more about that in the slides to come. So at first, key information about the actual go live. So the go live to Epic will be when we'll be starting to chart in the new in the Providence Epic instance will be on the 15th, which is Saturday at 2 a.m. So all of you on night shift on Friday night will be the ones going through this initial phase of the go live. For the first week, there will be super users available 24/7 on the units. There will also be informaticists on all of the campuses who will be roaming around helping people with issues and helping super users with issues. The lime green lanyards will be worn by the informaticists plus the super users. They'll have extra staff so that the nurses can kind of get through Epic, figure things out, but still will have patient care uninterrupted, and then also they're going to have more pharmacists, because this go live will definitely have a big impact on the pharmacist workflow. As far as where to find help, besides the people who are present, there's also you can also call the Epic help desk. Obviously, it's usually much easier to get a hold of someone in the middle of the night when I'm working, but hopefully they'll have more operators available during the day. They will have a command center on all the campuses. They're going to be taking tickets, issues that the super users and the informaticists aren't able to solve, things that need to be fixed, and hopefully they'll be fixing things as soon as possible as they come up. So all of the campuses have super users selected, and depending on the different units, they will have they'll have their own super users. And again, like I said, along with the super users, there will be informaticists available to assist them. Order sets. So order sets are really different in the Swedish and Providence system. The Swedish order sets, I know we're pretty used to them if you've been working at Swedish for a long time, but when you actually look through the order sets, they're quite jumbled. They are, everything is just in a really random order, and they are really hard to read. I mean, nurses joke that they kind of know what's going to be pre-checked, because most of the order sets are primarily just pre-checked orders, and they kind of know what's already in there, and it's so hard to read that a lot of people feel like it's pointless to try to look through every single order. Providence's order sets are really different. If you think of how Providence, instead of having 4 campuses that they need to have order sets work for, they have over 60 campuses. So this is a reason that it's really important for Providence to have very, I don't want to say vague order sets, but but order sets that are pretty sparse in their orders, and ones where there's a lot of choices for the providers to click on. And the good thing with Providence's order set, because we will be needing to read through the order sets when we go through, we won't have Swedish order sets coming over with us. We will be using completely different orders. But with the Providence version of order sets, they are organized much better. There's fewer of them. They make more sense. And Providence depends way more than Swedish on the actual policies and protocols and procedures as far as driving care. You'll see in the Providence order set that it says a lot about, vital signs per unit protocol, per campus protocol, and that's what we'll go by is by our protocols. Induction orders. If you can see here, this will be very familiar to you. You can see how long the order sets are, how everything is mixed together. You have, when to notify the doctor. You have multiple places there. There's all these different orders that basically say the exact same thing. 3 orders for administering oxygen, 3 orders for discontinuing oxygen, and it really doesn't make much sense when you're going through these orders. They're very hard to read. So here's another patient that I brought up in the new Providence Epic. And you can see here, I'm under the Orders tab on this side. So in Providence, you have just a few orders for the same thing. And the orders are all very organized. You can see there's one for vital signs, which you can see the header says OB per unit routine, which if we have specific vital signs for Swedish, which we will, they override whatever's written in the chart. Notification parameters, labor management, and when to start the epidural. I selected continuous fetal monitoring. And then you have things around straight cath, you have a diet order, a few labs, code status, and then you have medications. What's interesting to note is that, sorry about that dinging. What's interesting to note is that you have the oxytocin order, and the oxytocin order that actually is the same thing as putting in the whole oxytocin order set in the Swedish system. All of the instructions for running oxytocin are within the actual medication order. Something to note that I'm not sure if the providers are really aware of it, but should be made aware of it, is that the oxytocin order as it's written gives the nurse permission to run low-dose Pitocin, run Pitocin to augment the labor, and also to run postpartum Pitocin. So if the provider doesn't want the nurse to have all those orders, then they need to change the standard order instead of just clicking it. So anyway, something interesting to note. But you can see this order set is way more organized, it has way fewer things, and it's actually easy to read. I do want to emphasize here the importance when we go to the Providence version of Epic that you read your orders on every single patient. The providers are going to have a lot of leeway in what they can order, how they can order it. There's going to be a lot more medications available for them to order, and we're going to need to know how they're ordering things, and that is by reading the orders. Phases of care. I think that the nurses are really going to like phases of care. This is a way that the providers can order all of the orders for the whole phases of care, be it a surgery, so pre-op orders, intra-op orders, post-op orders, all at the same time, or in the case of a patient coming in to have unexpected vaginal delivery, they can put in the triage orders, the labor orders, and the postpartum orders all at the same time. And then as the patient moves through the phases of care, so when they're admitted into labor and delivery, and then when they deliver and finish with their recovery and go to postpartum, the labor orders will go away and the postpartum orders will then come up. The workflow around it is pretty straightforward, and it's really nice because you're not going to be dealing with the fact that the provider forgot to take the labor orders out or forgot to discontinue the anesthesia orders, so you have just piles and piles of orders from the different phases of care. This way, Epic kind of does the work for the provider. Order mode change. So these are the two differences in the order modes. Providence doesn't pre-select an order mode. I know sometimes when you go to the orders, it'll just pre-select forward torb or pre-select standard. Providence, you have to put them in, and they do have different names than the Swedish one. So just note these are the different ways of ordering mode when we're ordering an order as a nurse. Documentation. There's going to be a document coming out as of today, which is the 9th. I have not seen this document be published, so I am hoping it's going to be coming out pretty soon. They have told us that there will be minimum documentation guidelines for labor and postpartum also embedded in here, which would be great. So yeah, but these documentation requirements used to be, for the most part, in the order sets, and now they're not because we've gotten to Providence's order sets. So they've really had to rewrite their policies and protocols so that they're included in there instead. Big changes. Perinatal navigators. So I know all of you are aware of the loves navigators, and Epic really loves their navigators. I will say, as a nurse, charting within navigators is quite a bit more clunky than charting within the doc flow sheets. Nurses really love their doc flow sheets, and even when I talk to Providence nurses and say, "Hey guys, like, how much do you actually chart in the navigators?" Most of the Providence nurses say, I really don't. I kind of like charting in the doc flow sheets, even though it's a little bit trickier. So because Providence and Epic love navigators so much, they've made their navigators be really streamlined and easy in a way to chart in that it's mostly including the most important rows that need to be charted in. But that being said, clicking on buttons when you're using a desktop can be pretty cumbersome, which is how navigators are set up, as you know. Maybe someday when we are using touch screens, that would be a different story, but definitely the navigators as they're used can be a little tricky that way. So just know that that Providence and Epic in general do favor navigators. They try to make them a place where nurses want to chart, and you can take your pick for how you chart. But I'll kind of show you the benefits of charting in the navigators, and the benefits that of charting in the flow sheets. Because Providence loves navigators, they have a ton of them, and the navigators include just about every phase of care for the perinatal patient. I will say the arrival navigator, which is what we do in triage, and the admission navigators, these two navigators, just like in the Swedish system, are ones that have to be this charting has to be done in the navigator for the most part. You can see antepartum has a navigator, labor. This intrauterine one, this one is kind of handy because it's just sort of the bare bones charting that we do in labor: fetal heart rate, uterine activity, cervix, epidural. You've got one for preeclampsia and MAG, which can be helpful, and then the postpartum one also, postpartum also gets their own navigator. So here are some workflow tips. Day in the life of our patient. Well, here's the first tip: how to log into your department. Hopefully you've gotten this education before now, a few days before go live. But if you haven't, our departments have all had name changes. So when you go into the new version of Epic, we're all going to have the different name changes here. So you can see what the old ones used to be and what the new ones are going to be. The L&D grease board. The L&D grease board, I feel, is one of the things that was really underutilized in the Swedish chart. L&D grease board did exist. It sounds like the Edmonds campus used it quite a bit. You've got lots of different view of the board. It acts just like the grease board or the whiteboard that we have on our units. Let me show you how the grease board looks in sort of a live environment. I mean, this is a beta environment, so these are all fake patients, obviously, and so not all the data is in there. But I've had it open up to the All Patients tab. This is a tab that could, or this is a button that could work well for some of the smaller campuses. I know, like, say a Ballard charge nurse would be interested in being able to see all the patients because we don't have that many patients. With First Hill or the larger campuses, you can click on, say, just the labor and delivery patients, the labor and delivery and plus triage patients, and postpartum can click on delivered mothers and also well newborns to see what the status is with the different babies. The good thing with the L&D grease board is it has way more information. You can see it has birth weights, gestational age. When I click on a certain patient, it can give different reports down here, and you can see information about the patient without opening the chart. And each of the different grease boards has different information on here. Some of the questions people have as far as what different things are, the A stands for adoption. I'm not sure why it got such good real estate in the grease board, but it did. So the A stands for babies that are being adopted out. Fetal demise, FD is fetal demise, and you've got whether there's multiples in the room. The PPH risk, this is some scoring that's done in the Providence chart that looks at how high the mother's risk is for having a postpartum hemorrhage. You've got new orders results, all that good stuff. So it's very helpful information. One thing you can do, you can see here, my list. With this My List, what you can do is assign yourself to patients. In labor, this isn't going to be super helpful. I will put in a plug for it, though. On a campus like First Hill, where they're so busy, sometimes it's nice for people to know who the nurse is taking care of a particular patient. And since you guys carry around phones, you can put your phone number in so that they can see how to get a hold of you. I'll bring up the labor and delivery just to kind of show, so here's a patient that I assigned to myself, and I put in a fake phone number there, and you can see that that's a way people can get a hold of the nurse. I know some of you are like, I don't want people to get a hold of me. I don't want to be badgered. I know. But on a busy unit, sometimes it's nice. Also on postpartum, again, a shift like day shift where lots is going on, being assigned to certain patients, you get to use some more bells and whistles, which I'll show you when you've assigned yourself to a group of patients that you'll be taking care of during the shift. This slide just points out that the patient list still exists, but I will say, come on, postpartum, antepartum, really do try out the grease board and assigning yourself to patients through that. And it's just such better functionality, and you're going to get way more information from there. So I will say patient list is pretty old school technology the within Epic, and the grease board is where it's at. So if you can try the grease board out, use that instead of using the patient list and just seeing if you like it better. One of the enticing things is when you go to the Providence build, you're going to have to create, if you do use patient lists, you're going to have to create all of these things from scratch. None of the things will move over. OB triage. One of the things that First Hill has been trying to implement is the maternal fetal triage index assessment. This is something that A1 developed in order to help nurses figure out who should be triaged first if you have a bunch of people to triage at the same time. When you answer a bunch of questions about the patient, it will give them campuses. I'm not exactly sure whether it'll be implemented on all the campuses. I'm not exactly sure, but there is a way of documenting it within the Arrival Navigator, which is the one we use for triage. And then this goes through the assessment. I'm not really going to talk through it. It's something that you can Google and look up. So documenting for triage patients, there is a note now in the note editor. Let me show you that. So here's the version in Providence's beta environment. You can put in a note type for OB triage notes. It doesn't make the note do anything special, but it is nice to be able to recognize when the patient was in triage versus other parts of other times when she is in the perinatal system. I don't know if people are going to be moving the triage notes that perhaps are used on the different campuses. I know I'm moving Ballard's over for us, but if the normal triage note that you use hasn't been moved over and you don't want to move it over yourself, there is a smart text called PHS OB Triage Encounter. That is their standard triage note, and that is one that we can use as well. So this is just pointing out that we are going to use the Arrival tab within the navigators. The OB discharge instructions, they have a OB discharge instruction for the undelivered patient. They have it in all these languages, which will be nice. They have one that's specific to labor that adds a little more information about when to know you're in labor. Same with preterm labor. Same with high blood pressure. The high blood pressure one also is in 4 different languages, which is great. So these are all triage smart text that you can add into the AVS when you're discharging a patient from triage. All right. All right, admitting a patient. So I'm going to skip by this. Some of these aren't exactly helpful with the admission, so I'm going to skip by the first 2 and then come back to them. Arrival and admission. Arrival and admission navigators. So you've got the arrival navigator here and the admission navigator. The thing with the admission navigator that's really important is that when you use the admission navigator, don't have the first time you're using it be when you're actually admitting a live patient after go live. Please go into the playground and practice admitting a patient there. it's really important that you kind of get your head around what questions they're asking, because they do ask a lot more questions. It's going to take a really long time the first few times you do it. It's going to take longer than the Swedish one in general, because the Providence admission list of questions is just longer than ours. But practicing a few times will speed it up. Will speed it up quite a bit. So you can see these dots on the side here. All of these dots are red because the questions haven't been answered. Once you answer the question, then it'll turn the dot green. If you've started answering them but you haven't finished, it's going to be yellow. So one of the things that's going to come up right away when you're admitting a patient is the isolation screening. The isolation screening is something that we want to do right away. It's going to tell us if a patient needs to be on isolation. You can see a best practice alert will pop up and will recommend what kind of isolation this patient may have just from their answers to the questions. So looking at the admission navigator can be navigated there are some tools within the navigators that help us chart a little bit quicker and see more information. You can see here there's this one that says row info. What that is it's going to give this information. You really do want to click this one. Make sure it's clicked, because it's going to give you all the information about why we're asking these questions and what we're going to do about the different answers. Also, you have the last filed, which is also very important, because last filed will tell you if it's been charted on before and who charted on it. All choices, for some reason in the navigators you can have it come up where not every option is shown to you. So all choices will show you all the buttons that all the answers that you can give to the question. So that's another one you want checked. The details box, let me show you how the details box will function. That is a pretty cool functionality there that can help you get through the admission a little faster. So here's one of the screens in the admission navigator. We'll look at discharge planning review. So each of these boxes have that little green circle next to it. Once you get into a box, what you can do is you can hit the details box there, put a check there, and what it does is it brings up a details box, and you can click on it kind of like you're in a doc flow sheet. Remember when you're in a doc flow sheet and you have the thing over to the side and the sidebar, and it's sort of like that. So you can click here. If it's a single click row, then it's going to go to the next question. If it's a double click row, then what you can do is you can click on the answer, and then instead of having to go next and clicking there, what you can do is right click and left click. If you right click, it will go to the next section once you've left clicked on the answer. So I've clicked on the answer, and then I'm going to right click on my mouse, and that goes to the next one. So in the navigators is there's some keys that work well to get you through the navigators if you do use the keyboard, which can be helpful, and that is the F8 key, which takes you from the current space into the next one. So you can see you can't see I'm hitting F8, but I'm hitting F8 here, and that's taking me to different ones. So you can kind of hit F8 and then click, and or you can bring up the details box. The shorter ones, it's not quite as helpful to use the details box, but you can then go to each new one and click, F8 takes you to the next one. And and then F7 will take you back to where you were. So F8 and F7, that can be helpful in moving quickly through the different sections of the navigator. So one report that's really helpful if you're admitting a patient, especially if the patient has had previous encounters in the Swedish system, and maybe they had previous kids with us, or most especially if they go to a Swedish clinic, this OB professional exchange report pulls a lot of data from around the chart. Also, if you are admitting a patient to postpartum who had their baby on the labor unit, this report is very helpful to you as well. It's going to give a lot of background information. Let me pull it up here and just show you. So here's the OB professional exchange on a fake patient here that I have. You can see all the different things that are pulled in. Again, if it's a real patient, they would have more things in there. It's got some screening, this LDA body, kind of weird, the LDA body. So you can update how you want specimens collected. There's the orders to acknowledge. I can acknowledge those. And lots of different things. So the brain is something that they have instead of the work list. Work lists were something that functionality in Epic that the med-surg units and the ICUs really liked. It was a way for them to organize all the tasks they had to do for their patients. But the brain is one that was just developed. It's kind of brand new to Epic that we will be getting when we go to the Providence instance. I'm going to show you what the brain looks like on a patient here. So I've assigned myself, if you remember in the grease board, I assigned myself to a sort of postpartum assignment here. And the brain is this tab right up here. I click on that, and you can see all my patients here. The patients all have their own row, and this isn't a great example because the patients currently don't have any medication orders and stuff since they are test patients. But you can see that there are PRN medications and PRN tasks. You've got orders here, information about each patient. You can put reminders in. Obviously, these are geared a bit towards med-surg, where they have keys specific for ambulating patients and turning patients. But you can add a general reminder and say, okay, I'm going to add it to this patient here. And I'm going to say, check blood sugar before feed. And I'll say, I'm going to do it in an hour. So that will add that to-do task on there. You can do, you can look at the previous shift when the tasks were, the current shift, next shift. Again, I seriously doubt that nurses are going to just jump in and say, oh my gosh, I'm throwing away my paper brain forever. I'm going to go to this new brain. But as we get more sort of digital native nurses where they spend all their time on screens and very rarely write stuff down on paper, they may start to get, especially with the brain being kind of a brand new functionality that works a lot better than the previous ways Epic tried to help with this. I think it may be something that catches on. So, but you can see the orders here. They've got all these ones. You can acknowledge orders. And then this tells you that you have some charting to do for admission. So you can see here, we haven't done the length, weight, and head circumference on the baby. We haven't done the learning assessment. So those are a couple really nice things. So Swedish's care plans are, we basically, for this example, they're showing a general patient management care plan. For our care plan, I know that what most nurses put in is the labor care plan, the postpartum care plan, and for the newborns, the newborn care plan. And you got a couple teaching topics, that's it. It's very, very bare bones. Providence, compared to Swedish, has way more care plans. Way more care plans. Providence loves care plans, like your clinical instructor in nursing school loves care plans. So how to navigate the different care plans in the Providence system, because there are probably 5 times as many as Swedish has, so we need to figure out which ones we chart on. So I asked a Providence nurse, a friend of mine, what care plans do they document on that if we documented on those care plans, we would be fulfilling whatever criteria we need to have. She gave me this list of care plans. It's going to look weird because I have them all mixed together for the mom and the baby, but I just wanted to have it all on one screen so you can see which care plans they are. So the adult inpatient plan of care, that one is automatically wrenched in on all adult patients. So you're going to see that no matter what, added to your patient's plan of care. There's another one called labor. Labor has a bunch of stuff underneath it. I'm trying to see what I did. I added labor pain, I added tachysystole. Within labor, there's going to be a bunch of these problems, and as part of the care plan. This is just a few of them. There are a bunch more you can pick. The nice thing I like about it is you're not having to go out of the labor one and wrenching in pain, because I know pain is one that they want to see documented in the care plan, and pain is one of the topics you can click on for each separate care plan. You've got the postpartum vaginal delivery one and the postpartum cesarean delivery one. And you have perinatal loss. That's another one she pointed out. Hypertensive disorders in pregnancy. That's another one that they commonly add. And then for newborns, you have the infant inpatient plan of care. Again, for all infants, that one is automatically wrenched in. You don't add it. Epic adds it for you. And then there's this newborn one, which again, there are things you can add underneath the newborn. I have the pain. I also added hypoglycemia. So I mean, that's one nice thing is there's a lot of problems under each care plan. So you're not going into different care plans to add, say, hypoglycemia. It's not like the general patient management ones that we're dealing with. But yeah, if we were to say apply a template, and just to give you an example, the newborn one. So these are all the different ones that you can include in here. So you've got the temperature and stability, all that. So that just kind of shows you can pick which ones you want, but there are a lot under each template here. So documenting on the care plans. Documenting on the care plans is great. It is way easier than otherwise. Oh, and I should go back and say, just to show you guys, the number of OB care plans is gigantic. So you see all of these here. There's a massive amount of OB care plans, which is why I asked my friend, hey, can you just give me like the kind of bare bones ones that everybody charts on, that are the most common ones, and that you want to include. So I mean, for example, perinatal loss, you want to include it if the couple has lost their child. But what are kind of the ones that they always try to include if they apply? I mean, the list is pretty overwhelming. So, but that being said, you've got ones for breastfeeding, and you can definitely add those if needed. The lactation consultants can add those as well. But if you want to add breastfeeding issues into the care plan, that's another one that probably would be good. And if your patient has some weird thing wrong that is keeping them in the hospital, making it so they can't go home, I mean, you could probably add a care plan for it. I mean, that's kind of what care plans are for, is looking at when patients, kind of if you have a patient that can't go home, why they can't go home. So, show you that. Now, back to documentation. Documenting on care plans in this Providence Epic is great. I love it. Anyway, so care plan documentation. You've got your care plan here. You can scroll down, see all the different topics I have in the different care plans. There is up here, apply to all undocumented. And you can say ongoing progressing, and it'll put ongoing progressive for all of them. And then if you have some that you're like, hey, you know, the patient was breastfeeding terribly, now she's breastfeeding great, or, you know, now we've totally settled this, she's adjusted to her role transition, you know what, she's doing awesome, she loves being a mom, she has totally adjusted to her role. You can go and click on met with some of these, but if you want to just say, hey, all of these are still progressing, it just is one click right up on top, and that's it. The other thing that they want to point out is instead of having progress notes, so going back, this doesn't apply to labor patients. This is something that you'll see for postpartum patients and antepartum patients, where you're writing kind of a shift summary note at the end of the shift. They don't want those notes to be progress notes anymore. They want them to be called plan of care notes. So you want to be looking at the plan of care and kind of speaking to the plan of care in your progress notes. So, or sorry, in your plan of care notes. So you want to be speaking to the plan of care there. You can wrench in these plans of care into the note. Don't do that. Swedish has highly dissuaded people from doing that because it will give you a super long note that nobody's going to want to read. But you want to speak to them at least. So one way you can write this plan of care note is within the plan of care documentation. The other way you can write the plan of care note is just the same way you write all of the notes, which is in the note function. So coming here, and you've got plan of care note. You can just add it just like that, and then write your shift summary note. Nursing assessment and documentation. So the nursing assessment is not done in the Navigator. The nursing in the Providence Epic. And I will say, to be totally frank, documenting in the Providence version of Epic is quite a bit more cumbersome than documenting in the flow sheets and the assessments in the Swedish version. I'm just going to put it out there. The important thing to know when you're documenting in the assessment is you really need to chart by exception. If you have something in the patient's assessment that is WDL, within defined limits, you don't need to chart much more about it, because otherwise you will be charting all day long. Within each row, like you can see here, you have the cognitive neurobehavioral, is it within defined limits? And you put within defined limits. Within that, you've got the definition in that row information, but what WDL means. And if you are charting WDL, then the assumption is that all these things apply. So it's important to know what WDL means. And if there are no abnormal findings, they really emphasize you don't have to chart a whole bunch of stuff. Because again, the charting, the assessments, the doc flow sheets are massive. I'm going to be making some videos that look at the different doc flow sheets and try to help navigate. I'm not going to do it within here, but I will make some of those available just to help people know where to chart things and all that. Comfort with empty spaces. The Swedish doc flow sheets, because they were crafted with a lot of input from nurses, are really easy and streamlined to just go through real quickly, and it's easy to just chart something in every single row, and it goes pretty fast. In the Providence system, there are so many rows. I am not joking. So many rows, and there is no way you can chart in every one of these rows. The Providence nurses emphasize a lot that you cannot chart in all of these rows. It is impossible. You will be charting your entire shift and not be able to do patient care. So here is where the OB assessment is done. It's done in a doc flow sheet called OB-PCS body system. As far as why it's called PCS, that has something to do with the ICD-10 diagnoses. I don't know, but that's what it's called, the OB-PCS body system. You can see here all the different topics under here. It's a lot, and under each topic is a lot of rows. All right, skipping forward, epidural documentation. There are two places you can chart the epidural. One is under the labor or intrauterine OB navigators, and the other place is within the labor record flow sheet. You're pulling in all these epidural things. I want to point out there are so many rows to chart in with an epidural. Again, think to yourself, what rows am I charting in that you can get the information from somewhere else in the chart? For example, it has anesthesia provider as one of the things. The anesthesia provider is going to be charting in this patient's chart. Our anesthesiologists chart an epic, and they're going to put in that they put in the epidural. So is it required that we put in anesthesia provider? I mean, people can get that information from somewhere else in the chart. And in fact, it's probably better to leave that and let them get information from the actual anesthesiologist. There are some other things too, which if you're not sure what exactly they're asking, if it's not something that was charted in the previous version, as far as the what time they put in the epidural, what time the doses were given, timeout performed. Timeout performed is something that we have charted in the past, so it's something we can chart there. The test dose, we don't chart the test dose. The anesthesiologist charts the test dose. So, do you have to chart the test dose in Providence? If the anesthesiologist is charting it, it's kind of double charting. So again, it's it's an interesting thing. So something to look at. All right, there is going to be a new BPA for epidural removal, which is great. The postpartum nurses will probably be getting this BPA if the labor nurse doesn't take out the epidural, but at least it gets the epidural out of epic before the patient goes home. So it's 24 hours after it was placed that BPA will fire. All right, healthcare acquired infections, CODIs. I'm not going to say much to this. This doesn't really apply to our unit, but they are going from the Swedish nurse-driven Foley removal protocol to the Providence one. So, and the Providence one is located many places inside Epic. You'll see that you'll see it referenced in different spots in Epic. The MAR. So Pitocin. I kind of pointed this out before when we were looking at the different orders, but the Pitocin order, it covers labor, early labor, labor, and postpartum. So the provider, I mean, you want to get in touch with the provider before you just start Pitocin if you're not currently running it. But this order gives you permission basically to start it at any point in labor unless some of the instructions are taken out, which again, read your orders. And unlike our version of Epic, there aren't two orders. You know, of course, there's just this one order. Heparin sets, we do not run heparin at Ballard, so just kind of note the stuff on the slide. If you do run heparin, the pharmacists are going to be on it. There's a few changes. The changes are in red on this slide. And then OBIV insulin, there's a little change to the algorithm there, so just note the baby happens when you first click on this. So with the Providence version of Epic, they're using kind of they're penning the baby, which is what Epic actually wants people to do. Unfortunately, when Swedish went to Stork, they didn't do it in a way that made penning really practical or work well without screwing it up. However, Providence adopted Stork right away, and penning a baby there is much more straightforward and is actually the preferred way to go when you have a labor patient. What makes penning a baby different in the Providence system is when you click on the new baby button, it goes straight to pending. So you don't gender the baby, which in the Swedish system, it does kind of want you to, it gives you an option of gendering the baby, which is kind of the first step with admitting the baby. So I'm going to hit pend. What it does is it opens up the entire delivery summary. So there's no right or wrong way to pend a baby as long as you know this patient is going to be staying here. Even if for some reason you sent this patient home and she was going to come back, like you totally misguessed how her labor process was going, but it's okay. You're not admitting the baby at all. Pending the baby is okay. When I asked nurses when they felt the best time was to pen the baby, they said it really doesn't matter. It's just once she's admitted and you think she's gonna, and it seems like she's admitted for good and she's gonna deliver sometime during that hospital stay. So with penning the baby, what it gets you is the chance to start charting in your delivery summary, which sometimes people think, like how much charting is there? But there's actually a lot. I mean, as far as things you can do ahead of time, you've got let me see. You've got the anesthesia, you can do that. And the labor event times. But the nice thing is when the delivery is happening, you can chart things in real time. So you've got the newborn delivery here. You can put in like the head delivery time. You always wondered why was there a now button when we didn't even have access to that section. Well, now we do. So when the head delivers, someone can hit now, and then it puts in the delivery time, and then the actual delivery time for the whole baby. You can hit now, and of course it's like the same minute. It doesn't go by seconds, but if you're going to be charting a shoulder dystocia, you can put that elsewhere. And then you can start charting things, the nows, and then at that point, admit the baby. So the baby can be admitted at any point in this process. It's a separate thing. So the important thing, though, is that you put the time of delivery, that you make it the same as the admit time. So I'm going to hit admit. I just want to show you this process since there are a few changes. The sex of the baby, since we aren't giving it when we hit the new baby button, we can give it here. We'll say it's a male. Accept. Time of birth. I had already filled it in the delivery summary, so it filled it in here. So just make sure the admission time's the same. Another thing to note is that babies are admitted to their mom's room. So this is something different that you're going to see. So if the mom is in room 563, the baby is going to be admitted to room 563. And of course, I'm doing this from First Hill, so other campuses will have different rooms. You always have 2 beds in a room. I mean, hopefully you don't have triplets staying in a room, because where are you going to put the 3rd triplet? But I think they assume the triplets will go to the NICU. So, bed 1. So you can admit the other twin into bed 2. And I don't have to put anything there. Point of origin, born inside this hospital. And level of care, you've got newborn. So OR workflow, a lot of the stuff is the same. You have, one thing is just OR workflow instead of being called intra-op, it's called OR workflow. Also, the counts are called something a little different. Just make sure you've got cavity within a cavity. That's the uterus, the first close, and then the final, and then baseline is the initial count. One of the things that they're teaching us is that the LIP has to order a case in order to put a case in. I tested this out with our nursing supervisor, who is the one who puts cases in here at Ballard. And he did not need that order to be in order to put in a case. I mean, like, at least within Epic. So if you have like a HUC put in a case, it's okay. The HUC can put in a case without this order being put in, from what we could tell from testing it in the actual system, which is good, because the case request order, I do not think it exists in the new, in the Providence Epic. I cannot find it anywhere. Within our charting. So anyway, they will work through that, but in the meantime, a case can be created without that LIP order. Newborn admission, I went through these steps already with you. Newborn name designation is changing. We've got the numbers only when you have twins. You don't have them on regular. And newborn assessment, a newborn PCS body system. One of the things they wanted to point out, because it's not obvious, is where do you chart that the baby has breastfed, has pooped, has peed? Again, like I said, it's not obvious in the Providence system. So there are a few places you can chart it. If you want to really have a lot of description to it, you'll have to go to multiple flow sheets. But I'm going to show you many rows to chart in, and it's so hard to chart in the different assessment flow sheets. So they probably made this as something where they could put together all the things that nurses chart on frequently. So what you'll see in this one is the pain scale, some daily care things, and breastfeeding and output. The skin-to-skin contact, that one, it makes it look like that they chart it more than once, but I don't think that that we really need to chart skin-to-skin contact every single time the baby does it. That would be a lot of charting. So anyway, back to pees and poops and feeds. The rows that you want to chart the breastfeedings the breastfeeds in is this one, length of feeding, where you can type how many minutes the baby ate. And then breastfeed OCC. People are saying, what does OCC mean? What it means is occurrence. So breast occurrence, breastfeeding occurrence. There are a couple ways you can chart breastfeeding occurrences. If you, probably the best way to chart it would be when you chart the length of feed to just chart one underneath that. What Epic does is it adds up the number of occurrences, and then in the reports it'll say from 7 a.m. to 7 p.m. the baby breastfed 6 times, because you put in occurrence 1 and you put that 1 in 6 times. So the baby fed 6 times. If it was an insane night and you barely can get out of there with all the charting you have to do, it also works to put 6 at the end of it, but you're not putting length of feeds, which the nurses are going to want to know that follow you. But in desperation, you can put 6 at the very end of your shift, but don't do that. Just put 1 and then put how long the baby fed for. But anyway, your charting is your charting. It has the latch score here. The latch score is how we're going to score the feeds. We're not going to be doing, I can't remember what the old score was called, but we're not going to be doing the old long score. This one's a bit shorter, which is nice. 2 rows that I'm really kind of excited about are the feeding observation row and the feeding tolerance resistance row. So feeding observation, this is a way we can kind of judge babies when they're not feeding well. Again, if the baby's doing well, you can just chart like alert, active for feeding. There's all kinds of different, you got eager, alert, disinterested, distracted. I don't know. There's a lot of different things you can pick, but things that I'm excited about: 1, gagging, because sometimes you want to describe that the baby is gagging, and then chomping, munching, which, God, I hate those chomping, munching. I hate the chomping, munching in the babies. But anyway, it's a nice way to explain what exactly is happening during the feed. The other one is feeding tolerance resistance. This is where you can chart tongue thrusting. I don't know why tongue thrusting isn't in the feeding observation, but it's not, but you can put that in there as well. So probably they came from a couple different ministries of Providence, but so they got multiple places to chart the same thing. Alternative feeding method or supplementation. I mean, breastfeeding, you're already charting. If you're charting up here that the baby's breastfeeding, that's a breastfeed. To chart it down here and say breastfeeding, that's not I don't think really necessary. But if they're breastfeeding with a nipple shield, it is a way to put that they're feeding with a nipple shield. Or if they're doing any of these other interesting kinds of feeds. What they're feeding, again, like if the baby's breastfeeding and you're not giving extra stuff, but if you are feeding with a syringe, you can say you're feeding breast milk with a syringe, how much the baby's taking, and reason for supplementation here. Unmeasured output. So this is where pees and poops are charted. So urine occurrence, stool occurrence, and emesis occurrence. All of these, again, you chart 1 if it happens, and then that way it'll add up how many pees the baby had, how many poops the baby had. So when you have a pee, you put the time and you chart 1. I know it's weird, but that's how they chart it. If you want to describe the pees and poops, it is not easy, or the emesis, what you have to do is go to the newborn NICU patient profile, or no, sorry, you have to go to the newborn PCS body system. You have to go down to gastrointestinal and large. I mean, do you have to do this with every single one? They don't make it easy, right? So do you really want to chart in multiple places just to describe the stool? if you chart that the baby pooped, is that going to be enough for the pediatricians? I mean, these are all things that we're going to have to work out because, again, we don't want to be spending all day charting instead of taking care of our patients. With voiding, so again, to get a place to be able to describe the pee, you basically have to wrench in urine characteristics, add it into the flow sheet, and then putting it here, describing it, yellow. I don't even think there's a uric acid crystals in there, so clear. Again, when you're describing, when you are doing the assessment on the baby and you're saying within defined limit, it says urine color yellow, void spontaneously, and then documented void by 24 hours post-birth. So, if you don't have to describe the color, if you're saying WDL, unless it changes and you put NWDL at any point, if the pee turns red or something unusual, then that's something that you can describe. But WDL means that the baby is peeing yellow urine. So that is something about that. And the GI WDL, again, I mean, you're just saying everything is normal. And if everything's normal, do you have to chart a bunch of stuff on top of that? Maybe you can chart it once or twice, but again, you got to take care of patients too. And as long as you're charting how often the baby's pooping, that's half the battle. So point of care, what this slide is saying is that we're not going to be having, we're not going to be able to just chart nitrazine positive as a row selection. We actually have to get an order to do nitrazine or an order to do ferning, and then when you do that order, you will have a place to chart it within results review. Enter edit results. So certain things like things from blood gases, like the machine to do blood gases, and the glucometer, the iStat and the glucometer. If you use those will result in EPIC, but things like fern, nitrazine, those ones will not. So we have to add those ourselves, and I will say it is a hassle. It's a hassle compared to how we currently do it, where we just put it in a row in the doc flow sheet. But this way, it does show up in results review, makes it more official, so that's good. Let me show you how exactly that's done in the chart. So one thing that you're going to want to do, either in the EPIC environment before we go live or after go live, is to add enter edit results into the sidebar here. If you look under more, you can see enter edit results right down here under allergies and contraindications. So the way to add it, or to add anything into your sidebar, is with this wrench here. So I'm going to go here, and then we're going to find enter edit results, and I'm going to just move it over there, just so got it like that, and we'll hit accept, and then it's going to be there. Not every single person has to do it, but if you're doing any tests like the fern or the nitrazine commonly, that helps. So I've already put in a nitrazine test in my patient's orders, which is the POCT vaginal pH. So I'm going to click on it here and then edit. And then I'm going to put the value, so I'll say 7.5, and then I'll hit accept. And now it's off of here. And if I go to the results review, which I have to find results review, there you go. one thing about results review that just want to point out, it does have a selection that's results since conception. So results for the pregnancy, which is pretty cool. I'm going to say that. And you can always uncheck this if you're like, you know what, I'm only going to want results since conception. You can uncheck that, and that'll keep that as your default. So we've got the vaginal pH 7.5. You can make notes when you're editing the results. You can put notes in there and say like, oh, positive or whatever. But I just put the number in for this example. OB hemorrhage. So one of the really great functionalities that Providence's Epic has is the way that it allows Epic what these things look like. So the OB hemorrhage navigator, this is a way that you can chart a hemorrhage really quickly and get the orders up really quickly. One of the ways we can the navigator can be reached multiple ways. One way is by highlighting the person's name here and then clicking on this button, OB hemorrhage. So this is within the grease board. If for some reason you are in the L&D manager, you can do the same thing. You can highlight the patient and go to OB hemorrhage here. I'll go back to there. So when we highlight the patient, we go to OB hemorrhage. It's going to open up the patient's chart, and it's going to open it to this OB hemorrhage screen. If you are in the patient's chart already, there are multiple ways you can get to the OB hemorrhage navigator. One is through the OB navigators. You can click on OB hemorrhage there. I thought maybe you could do it through the flow sheets, but maybe not. But anyway, that's fine. So I'd already opened it, so I'm going to go down here. The OB hemorrhage navigator, it's very simple. It has information there. It shows that during admission and through the stay, the patient was deemed to be a medium risk for hemorrhage. But the important thing, though, is if the patient is in the middle of a hemorrhage, you click this button here, and you have a postpartum hemorrhage assessment. So you can look at these various stages, what they mean, and you then say, okay, I've got this patient. She has passed to stage 1 already. She's now in stage 2. So hopefully this will be charted by some lovely coworker of yours who comes in to help and wants to be at the computer and does charting while you're dealing with the hemorrhage. So say she deems it a stage 2 hemorrhage. What you have to do after you deem it a stage 2 hemorrhage is you have to hit next, because that is what's going to file it. And then what happens is all these things are ordered for a stage 2 hemorrhage. And then you can hit accept and you can order those things. And I believe, I just forgot to do the allergies. Sorry about that. I'm also going to try out if you do stage 1 hemorrhage and hit next. That orders these things as well. So it looks like you have to do stage 1 and stage 2, and that will give you all the orders you want. Someone had asked me in a class if doing stage 2 will include stage 1, but it doesn't look like it. You have to do stage 1 and do stage 2. But luckily, it's just clicking a button, hitting next, and that's it. So it's really straightforward. So I'm going to accept these orders as well. And type in cross match. So I'm going to go down here, sign the orders, and they're verbal. And I'm going to put in Anderson. So it's sending all those orders out. If you're within stage 3, also next. And it's just stage 3 management, massive transfusion protocol. Consider massive transfusion protocol. So within the stage 3 management, you'll see all these different things when you click on it. You can click on it here. You can click on it in the actual, within the orders, the active orders report. The postpartum hemorrhage protocol up here, it's Providence's protocol, but their protocol is almost identical to ours. We developed our protocols together. It's following CMQCC, so if you use this, you're reading this, it's going to be pretty much the same thing. Here they're talking about medications. I just want to note one of the fantastic things I really love about Providence's instance is within the order sets for labor, C-section, and postpartum, they have all of the hemorrhage meds available, pre-checked, so nobody can not check them. They're going to be available in all the different phases of care. So yeah, that's going to be really great. So when you are looking at, the stage 1, stage 2, stage 3, the orders you get, none of them are the medication orders because the medication orders come standard in the labor, C-section, and postpartum order set. So those ones are already ordered. You're already giving those before you even have to do the staging of the hemorrhage. One thing that is good to note as well, just so you have the information, when you're going to the navigators and you do the admission, things you're going to be asking about is the risk factors for postpartum hemorrhage, which we currently do, but this way is a little more savvy and it actually adds things up. The other ones we're saying low, medium, high. This one, they're just asking for risk factors and then they determine whether it's low, medium, or high. So I'll say low-lying placenta. Let's see, previous postpartum hemorrhage. Is she actively bleeding? No. No previous, but is patient pregnant with multiples? Yes. And so we'll hit next. And then when you go to the summary report, let's see, I'm in OB Suite 7. So you can see the patient is yellow, which is medium risk. So that's something. But when you are in, when you're documenting things in the patient's flow sheets, let me click here under labor and you're looking at OB hemorrhage reassessment, this one here. And they're saying, is the patient actively bleeding? Is choreo suspected? We can say, oh, sure, she has choreo now. She's been on Pitocin longer than 24 hours. We've got these. And then we'll see, does it bump the person up? Nope, not yet. So anyway, so low, medium, high. And then if they reach a higher level, it will say, you need to do XYZ, you need to order these, you should do a type and screen or whatever on the patient. And you can see it up in the header as well. And that takes you to this. I'd forgotten that. Okay. So once you know the patient's risk factor for risk factor low, medium, high, then you can see what you need to do, which is to order a type and screen. So blood administration. To administer blood, you need to do a pre-transfusion assessment, which the majority of it is within the blood flow sheet. Unfortunately, I'm sure Swedish's protocol has something about GI and pain and skin, and which in the Providence instance is not in the blood flow sheet. So it looks like they want us to go over to the PCS flow sheet and document it there, which obviously if we're in the middle of emergency, we're probably not going to be able to get to right away. And you've got, once you have ordered red blood cells, the transfusion order, this transfusion release report here, that will send you, that will print out a requisition to take to the lab. So hitting this release button here, clicking there, clicking here, and then if for some reason your computer's or your printer is jacked up, you can click here to print it again. Charge capture, I am pretty sure everybody is so overwhelmed with everything. They're kind of putting charge capture on hold, keeping the same workflow that we already do. But just know that there are ways to capture charges in the new Epic that are captured in the doc flow sheets, in the navigators, in different parts, in the OR charting, where all the charges can be captured within our regular charting. So, new assessment tools for pain. You got these ones. The NPAS. So we still want to use the NPAS. Swedish has decided that. However, the newborn pain assessment tools are different with the different Providence locations. So you have to wrench in the one you want. I think NIPS may be one that's already wrenched in, but we want to continue with NPAS. So you need to go to preferred pain scale, which is under the newborn PCS body system, and use that. NAS scoring, that one is under neuro, additional documentation, and then you can add the Finnegan scoring there. So again, under newborn PCS body system, and you can see all those rows there. Breastfeeding hand expression, I kind of went over that already. All those things. I will, you know what, I'm going to show you what some of them look like in Epic, just all the places you can chart. So I want to talk about breastfeeding and charting breastfeeding. So I already discussed where to chart the feeds and how to describe the feeds. That's within the Well Newborn Quick Chart. But there's also a lot of rows around lactation, breastfeeding. You guys will see these throughout the chart. You'll see them as part of the admission. You will, there's a couple doc flow sheets, one called Lactation Baby, one called Lactation Mother. These go really into the weeds and I think are just best left to the lactation consultants to chart in. You also have in the mom's chart, you have, let's see here, you have stuff in the postpartum doc flow sheet. You can see there's a lactation section here that's really long. And there is a row called breastfeeding assistance that has all these different things in it, you know, help with hand expression, family support and courage, both for soft reduced feeding. The thing with all these rows, and then that's not even including the OB-PCS body system and all the lactation stuff here. The thing with all these rows and all this information is, much like the Swedish version of Epic, some of these rows you're asking the question, but the question is, the important question is, where is the data from these rows going? So you're putting in that you helped with hand expression, but does that row feed into any report that that anyone is going to see? If you chart it every 2 hours, is it going to show that is someone going to be able to easily see in the chart that you helped with hand expression every 2 hours? Plus, there's a lot of other things in the chart that talk about, you know, latch promotion, and then what size of pump flange they used, what size of nipple shield they use. Did you talk about, you know, when did you start pumping, what type of home pump they have? I mean, there's just so many, many, many rows to chart on regarding lactation. I feel like what is going to be helpful as we go forward is lactation is a great group that is very active, and what I'm probably going to encourage them to do is figure out what rows are helpful for them if we charted them and which rows aren't. Again, they want to see how many feeds the baby has, a description of the feeds, which again, all those things can be seen in the newborn quick chart. But as far as like what you did at different feeds, again, if you're racing all over the chart, clicking into different flow sheets to chart one thing, is that going to be helpful versus just writing a note saying that you helped with hand expression? This is something I'm going to explore as we continue to work in the system. I've talked to nurses who currently work in the Providence system, and they say it is really all over the map, and that they tend to chart less than more because they also don't think it goes anywhere. But again, some of the rows might. So that is something that lactation will have to look into and then make some recommendations about what is helpful for us to chart in and what's not. Yeah, that's what I have to say about that. All right, OB mute scores. The OB mute scores, maternal early warning trigger. So these are scores. This is a score that you get that's based on the vital signs in the chart. So there is a module that talks about the mute score, and it's something that's going to fire off a BPA, best practice alert, and say, hey, like this one down here, and say, hey, your patient's heart rate's 155 and her temp's 103.8. Like, you should probably call the provider and see maybe she has, I don't know, maybe she has some sort of sepsis. So anyway, these are the things that'll trigger it, and these are the readings that'll trigger it, and it's something that goes over time. Restraints, I'm not really going to talk about restraints. I don't know. Discharge, so we don't have standard discharge instructions anymore when we go to the Providence system. Providence may have some standard ones, but it's something that we can maybe decide as a hospital system to use particular discharge instructions. But as far as I know, the discharge instructions aren't necessarily moving over as a standard discharge instruction, like someone from on high is telling us to use it. I'll probably move over the discharge instructions because I like them for mom, but here you've got the discharge checklist, all that stuff. And of course, discharge instructions are part of it. With the discharge checklist, what's really nice is it is a sidebar, so you can go throughout the chart and keep the sidebar open. There's where you get the follow-up and instructions. Newborn discharge checklist. We don't have the old one like we used to at Swedish, where it was just check, 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 check. They're all in the same spots. Cord clamp removed is under cord care. Again, here, let me bring it up. So within the chart you have the discharge checklist. It shows that you still need to do the cardiac screen. If I click on any of these, it'll take me to where it's meant to chart them. And you'll see the newborn screenings here. The EOS screen will appear from the delivery summary. That's an automatic, that will automatically calculate when you fill that out in the delivery summary, or sorry, it will fill itself out and automatically calculate when you're doing the delivery summary. Infant screens, this one, if you click on it, what it brings in is the car seat testing. So if you're wondering where to chart car seat testing on newborns, this is where you can wrench in those rows. The bilirubin is here as well, so you can see the results. These are all kind of together, which is nice. One really, really, really cool functionality of the Providence build is they have a billigram that lives inside the their version of Epic, and it automatically does the calculation for us. It's showing that this baby is 12.2, which at its age is in the high risk zone. If you click on the billigram here, it'll actually mark it out for you. You can see that. It's pretty awesome. I really like it. It calculates itself because it knows the baby's gestational age and weight and its hours of life. So I am a big, big fan of that. And again, you can get to it. You can get to it down from the newborn screening, from that bilirubin row, or from the risk zone row. So one thing I wanted to point out with the newborn AVS is the newborn AVS actually has a lot of permanent things in the AVS that you can't take out, and one of them is actually the discharge instructions as far as when to call the provider. These ones will show up here no matter what. There's no way to take them out. So we don't actually have to add any other discharge instructions except maybe to refer people for newborn care, to refer them to their postpartum guide that we're sending them home with. The really cool thing with this is it'll translate into this different languages. Oh, here's when to follow up, and then the clinical information. That's another thing I wanted to point out that's really awesome. It'll say birth weight and discharge weight and the amount of weight loss. A lot of people, it's helpful to know that. And then the Billy and the cardiac screen and the hearing screen. All those results will feed into there, plus the time of birth. So that is automatic. It will automatically go in. The other cool thing I wanted to show is this, because it's like basically a permanent part of the discharge instructions, they have it translated in a bunch of different languages. So you can see it has Arabic. So if you wanted to put it into Arabic, it will put all those warnings and when to call the doctor into Arabic. German, which is interesting. I don't think German actually works for this. Spanish. Has Spanish, it has even the correct characters in anything with like Mandarin. These ones unfortunately don't translate into Mandarin. But yeah, but that's actually pretty cool. The one thing that the Providence nurses warned me about is that you need to print out one in English as well when you're going through it with the interpreter because it's not going to print out an English version for you, and you're not going to know what it says when you're going through it. So yeah, so these are the interesting things with the newborn discharge instructions. Obviously, you can add more discharge instructions if they need certain things put into their extra, but if it's something that can be covered with the postpartum guide and the when to call your doctor, those ones are automatically in there. So here's where you would add the discharge instructions. And one more thing that they wanted us to point out is where certain kind of one-off things are in the chart. So electronic transponder number, that is the Hugs tag number. So a place you would chart it is the Well Newborn Quick Chart. There. Fourth band holder is actually under this patient profile. The patient profiles, the OB patient profile, the newborn patient profile, I will be honest, when I talk to Providence nurses, how much they chart in there, it is really not much. There's certain rows that people can say, oh, I got footprints, footprints obtained. When the cord clamp was removed, this is a spot you can do it, on what date. And the fourth band holder is down here. So, yeah. Again, sort of odd rows, many, many, many rows. You can see all of these. Lots and lots of rows. But they do want us to chart the fourth band holder. They do want us to chart the Hugs tag number, and again, to take the cord clamp off. It's right here in the top section. So resources and tip sheets. What can you find online? Let's see. The first one is on the within Swedish online. You can find at the bottom of the page, it has the informatics and CIS, and then you can click on Epic Learning Resources. This you can actually get to from home. It's epiclearning.providence.org, and then you can log in when you get to that page, and that will give you a lot of tips and tricks. But the important thing to do is to get into the playground and really start working in the playground and trying all these things out, going to the different doc flow sheets, the different navigators, and figuring things out. That's kind of the easiest way. What we don't want is for everything to be a big surprise, because you know what? Change sucks. Change is not fun, and it's going to be a big change, and we want people to kind of wrap their brain around it before they're actually navigating it in front of our patients, because our patients are going to wonder why we're freaking out, because there'll be a little bit of freaking out with when you're looking at the new Epic. So here's those tip sheets for the Epic Learning Resources page. And then this is what the link looks like for the Epic Playground. So you would go down here, and you would have the Citrix little icon right there that you'll see, and then that will open up this page, and you want to make sure to do Hyperspace Playground WMPT. PT stands for Pacific Time. MT stands for Mountain Time. That's the one that Montana uses, so don't use Mountain Time. It's going to give you a really weird environment and not let you chart anything. And the standards will be here. Change is the only constants in life. I'd ask if you have questions, but you are just listening to this and not in front of me. But if you need to contact me, I am happy to answer any questions you may have. My email address is sarah.temba, T-E-M as in Mary, B as in boy, A, at swedish.org. So yeah, I will be navigating all of my notes over. They'll be fun and have lots of drop-down things, and so I will be bringing those over when we go to the new instance. So if you do want to share my notes, you can look for them in the note navigator. Let me actually show you how to do that. The Smart Phrase Manager here. You can put my name in there, and it'll go to my smart phrases. I'm in the beta environment right now, but when we're in the live environment, you'll see a bunch of smart phrases that I have there. So anyway, you would open this up and then you would type my name here.